Tuesday. Good afternoon. Still waiting on a few folks to join, so we'll just wait a few minutes before we get started. So I know we're expecting about 2 or 3 other folks to join us, so I'm just going to wait 2 more minutes before we get started today. All right, well, I show, okay, here come some more folks. Okay, I think we'll go ahead and get started, and hopefully others can join us over the next couple of minutes. So good afternoon, everyone. Happy Tuesday, and welcome to the Bureau of Primary Health Care's Pain Management and Alternative Treatment Modalities Community of Practice. Today is learning session 11. And as you know, today's session will be focused on hearing from you all with an opportunity for others to ask questions, share resources, provide insights or recommendations to one another. We do hope that this COP report out process has been helpful for you not only to gather as a team and learn more about this topic, but also really to use this as momentum to move pain management forward in your health centers. We've heard from some other programs who have used these COP report out presentations to bring to internal staff meetings or board meetings to inform other colleagues of the work you've been doing. And so we encourage you to consider that avenue as an opportunity as well. We do have one guest on the line today. Lara Chauso is new with the Bureau of Primary Health Care, and she has joined us today to observe and listen in to familiarize with the COP process. So I just wanted to let you all know that Lara is on the line. She did ask me to let you know if you would prefer to present with her not on the line. She is happy to leave, but is planning to just observe and listen in on all of the great work that you have been doing over the past few months. So before we get started, I just wanted to kind of take a minute to add that we, as facilitators, are just incredibly thankful that you all have hung in there and participated in this community of practice over the past few months. Obviously, the time that we've had together has been during a pretty challenging year for the whole country, from COVID to the calls to action to the wildfires in California and Colorado. And so all that to say is that we're just happy that you have stuck with us through everything else that's been going on and prioritize this learning collaborative when there are many, many other pressing issues going on. So just thanks for all the work that you've been doing and continue to do at your health center so seamlessly. And since we have been doing much of the talking over the past few months, we're excited to turn it over to you all. But before I do that, Erin, was there anything you wanted to add before the presentations begin?
No, thank you, Amanda. I just wanted to kind of just echo your comments about, thank you all for, hanging in with us and, staying with us, while all the other, all the things that have been happening this year. Certainly this was a bit unusual in terms of the circumstances in which we are operating in, across the country. And we really hope that, the information we presented so far has been valuable to all of you in terms of the work that you are doing, and that is really still ongoing and, will probably be necessary for some time to come. So, glad that you all are doing that. And, today, as Amanda said, is really a time for us to hear from you and for you to talk with your colleagues to get a sense of, what has this COP sort of struck up in your minds or in the minds of your group to sort of get together to try to do to improve health outcomes and, reduce opioid misuse within, your organizations and really essentially move towards sort of better care for your patients, which is something I know that is important to all of you. So I really just wanted to hear from you in that regard. And I think, Amanda, you said that we have about 2 sort of formal presentations, I guess, and then 2 others that are going to give a bit of an update about kind of where they are and sort of what they're thinking about going forward. So with that being said, I'll stop because really I think today is a day to get to hear from you all about your sort of, what you've been up to and sort of where you're headed. And then we can chime in or you can ask questions of your colleagues as you see fit. So thank you for the work you're doing, and I'll go off of camera right now so that we won't have any sort of bandwidth issues as people are presenting and the like. So
Great, thanks, Erin. Yeah, so we have 2 presentations today and then 2 kind of updates that we will also provide at the end. So I think we're going to start with the 2 presentations, first from Cahaba Medical Center, and then second from American Indian Health Services team. So Nina, if you could upload the slides from Cahaba, and I will turn it over to the wonderful team at Cahaba Medical Center.
Just want to check, do you guys see the right PowerPoint?
Yes.
Okay.
We're ready to start.
Sorry about that. Let me fix that.
Do you want me to share, Mina?
Let me just do one more share screen. I think me having 2 screens is a little glitchy. Sorry. Does it work now?
We can still see the next slide, but I think that that's okay.
So you don't see it in presenter mode?
Mm-hmm.
Okay.
Okay, I can go ahead and start. My name is Ebony Whitby. I am, as you can see, I'm the Substance Use Disorder Coordinator. And for this project, I was joined by Mackenzie Duckworth, which is going to be our pain management group facilitator. Well, she is our pain management group facilitator. And then Charity Lester, which is our Director of Behavioral Health. So we've been working together. You can go to the next slide. All right, our goal was to basically our patient will accept the role of pain in their life and acquire and utilize necessary pain management skills to have a better quality of life in 8 weeks. So what we did was created an 8-week pain management group that is composed of both talk therapy, we'll say, and actual physical exercise. So our activities, we said that the patient will attend 6 out of 8 group sessions, focus on learning how to manage pain and improve their overall functioning. And then they'll also become more knowledgeable of the role of medication and treatment process and implement skills learning group at least 4 out of 7 days a week. So those were our were our objectives to go with our goal. Next slide. One more. All right, thank you. So some changes for us, we had already been talking about starting a pain management group because we do have a substance use program, and that was where a lot of our patients were already prescribed Suboxone and had a history of pain. So for us, this COP was like a catalyst for starting the group. It was very informative and provided us with the extra push and motivation and even information to get started and structure out the group. And so for our next steps, we're going to continue to hold our pain management sessions and assess the progress of the clients and make adjustments as needed. Next slide. All righty. So some strategies for success for us were that we already have we already have our SUD program in place. So it created a foundation for us to just go ahead and add the pain management group as an additional service to our patients. And then we also partner with several of our medical providers, our DOs specifically, that are trained in holistic pain management. So they also add a portion into the group sessions because the patients will be seen by them as well as the talk portion and the exercise portion. Some challenges that we have an exercise portion, and because of that, we had to add an additional copay, and it has become kind of a discouraging piece for our patients. Also, and so that goes with the second thing as far as getting patient buy-in for an 8-week commitment on type of additional copays that they would have to pay in one day because they have to pay the medical and the exercise copay. We also had a time trying to find an evidence-based practice curriculum that was formatted in a way that we would find very useful for our particular client population. And then another challenge was actually coordinating the clinic flow to get the YWCA, our counseling department, our receptionists, and medical providers on the same page so we can have a smooth flowing clinic. Next slide. So things that we learned were to be flexible. We actually tried to start our group probably a week or two before we actually started, but we did have some of those challenges mentioned in the last slide. So we had to remember to be flexible and really just start. Having realistic expectations, knowing that the initial start of anything new is not going to look like you probably thought it would. It's not going to be a perfect flowing machine in the beginning. And so having realistic expectations, and then we did also realize that patients participate in things at a medical office when a medical provider is present. So if their doctor, nurse practitioner, things like that are involved. And then for our next steps, we're going to, like I said, continue assessing and just making the group better. Also, we will start marketing to the Y members and then expanding it to our other clinics that we also have. Next slide. That was just for questions that you all might have.
Okay. Thank you, Ebony, and thank you, folks. This was good. So I guess I can jump in and ask a couple questions here. What I really appreciate kind of the work you guys have been done putting together the pain management group and some of the pitfalls, and maybe as something to think about going forward. I'm wondering if we can put it to the group. has anyone looked at sort of other resources to help, like maybe defray the cost of the YMCA? Is that something that you all are looking at? And are others on the line, have you all done any work that may help them as they think about that?
So we've actually talked to them about a portion, like after they finish the initial 8 weeks, to get a discount, because they do have a program they can apply for that would make the membership price significantly less, but we're still in the process of trying to figure out what to do about the initial fees, because it would be like $50 for the exercise portion for the initial 8 weeks. So trying to figure out a way that we might be able to, we talked about maybe like a gas card or something like that, that would be an incentive and kind of almost trade off for people to participate, but we haven't figured it out exactly.
Okay. That's an idea, something like a transportation voucher to help defray some of the costs that maybe they might be willing. That makes a lot of sense. Okay. Looks like we have a couple questions in the chat box. One just sort of generally is a question, looks like from Keith, about how did the collaboration go with the Y? They're saying that they had some trouble bridging the gap between the instructors. And then also, are the classes at the clinic or at the Y or both? How are you guys structuring it, the location there?
Okay, so the process with actually linking and collaborating with the Y went a lot smoother than we thought, because we're in a smaller town and they actually really like the idea. So fortunately for us, they had a lot of buy-in, and they're actually sending an instructor over to teach the classes in our clinic. So we have an extra room that we use for group and different things. And so it's big enough to do the classes. One thing that the Y was already doing themselves was the person in charge said that they had already sent several instructors to learn how to do chair yoga and different things for elderly and disabled people. So for them, it was almost right on time, because they'd already been trained in some of these other, we'll say,
alternative methods
or exercises. Yes.
No, that's great. What other questions for the group? Excuse me. The only other question that I had while waiting for others, if they want to, type into the chat box or unmute their line and then sort of come up with any other questions. One of the things, the other question I would have is, as you guys move forward, certainly there's the working on how to defray that cost. It sounds like you have maybe a couple of ideas of a trade-off or some other things, but are there other things you'd like to do, within a year or, 6 months or a year from now, or other things that you want to do to sort of expand kind of the work, given that you've seen sounds like some level of success with this? Where do you want to go from here?
So we definitely want to expand to our other clinics. We have about, I always joke and say 1 million. In real life, it's probably about 8 to 10 other like actual physical primary care clinics. We also have dental offices, community centers. So to expand to our other clinics in the other county that we're in as well. So truly getting a well-structured program that can be duplicated in other areas by other providers.
Got you. Okay, that makes sense. Okay. Looks like we have one more question that came in from Keith. And so he wants to know, did you or are you collecting outcome data, patient satisfaction data, or do you have some general sort of idea of whether the people who tried it feel like they benefited?
Okay, so I didn't mention, we do have a, again, did I tell me, my mind just went blank. We are using a...
So we did the SOAP at the beginning, and then the RAND 36 at the beginning.
Okay, so say those twos again for us. So I'm sorry, I missed the first part of that.
We initially did the SOAP 14, SOAP R 14. And then before the class began, we did the RAND 36.
Right. And so we'll be doing those again at the end, just to have a structured survey, and then also ask them how they feel at the end of the group. Do they feel like they're able to do more things as far as like a general satisfaction? And then when it comes to, I think that was that first question. And next for social distancing, we actually, oh, another thing that we're doing, the DOs are actually going to have appointments with them for actual adjustments. So that'll also be something that we'll see if that helps them in their progress.
Okay.
And then for the social distancing, our room is actually pretty large. It's probably the size of someone's typical conference room, but it's an open space. So we're able to put chairs in there. We have like yoga mats, they have the dumbbells and other little exercise equipment. But like I said, the Y had already been trained in doing like chair exercises. So it's not like they're physically running around or anything. It's actually like you can be in your own little bubble doing your exercises in a safe distance away from others.
Gotcha. Okay. That makes sense. Okay. I like the idea of you guys doing that sort of those pre and post kind of assessments, looking at, I guess, functionality and some other things to see if they're making any improvements. Like I like that as a good piece on this to see if you can get good data out of it and continue to, as you said, expand it to other clinics. So any questions you have for the group or other things you'd want any responses to?
No, I guess I'll just we'll be interested to see like what other curriculums anybody else might have found. Or I know for us, we found like 2 or 3 and we just kind of combined them to fit our needs. So if anybody else had any curriculums that they just absolutely loved or it works good enough, I would be curious to see that.
Got you. Okay. So maybe it's folks think about this, maybe putting their curriculums in the chat box to see if, anything that you guys like, we can share that through the chat. So good, but thank you. Thank you guys. Thank you for participating and for the presentation today.
Thank you.
Thank you. That was wonderful. All right. We're going to turn it over now to the team at American Indian Health Services. If you're trying to speak, I think you are muted. Do we have Carlos or Brad or Natalia or Vivian on the line?
Hello. Can
Hello.
you hear me?
Yes, we can hear you.
So, hi, this is Natalia. So I'm not sure if Carlos is muted or what's going on. Oh, I see in the chat he's trying to unmute his phone.
Mina, are you able to unmute the 180533 number in that called in?
I am not. I can try to ask him to unmute, but I'm not sure if it pops up on his side. Could he call in one more time?
And then I see a chat from Bradley. I can't log in for audio. He can hear us, but he can't speak. So there's no way to unmute Carlos's line.
No, but I think the best option is to call back in.
So I think the line is automatically muted when everyone joins. Is there a way to switch that at all?
Not for this phone number, no. Because this one's, I'm asking him to unmute on his side, and I don't think it works on his side. Like, you can't.
Okay. So maybe if you might be able to work with Carlos offline, maybe we can move to one of the other updates and go back to AIHS afterwards, if that works for folks.
Yeah, I can do that.
Okay.
Yep, I think we can do that while Carlos is calling back in.
Okay, great. So if we could get an update, Drew, I don't know if you're on the line and would be able to provide an update for the Marillac team.
Yeah, absolutely. Yeah, thank you for allowing me to kind of talk a little bit about what, the goods, the okays, not so goods of what have been kind of transpiring for us over the course of those several months. Just to kind of give you a little bit of background here for all the participants. We initially started, so I work here as one of the health coaches. I don't have too much familiarity with chronic pain. That's not necessarily so much my background, but what the chief operations officer and the director of behavioral health, who was doing those two positions at the same time, thought it could be beneficial to get the health coaches involved with this, being that we cover a lot more of the whole person health, nutritional counseling, physical activity, sleep, stress, substance use. So really our position was very relevant in many ways. So I am pretty honored that she did choose us to become part of, affiliated with the group. That COO and director of behavioral health, unfortunately, is no longer with us. So she was kind of like the lead role in this effort, or I should say in this movement. So towards after she kind of left the scene here, we hired on a associate director of behavioral health, who then was also going to be a part of this collaborative effort too, along with one of our behavioral health providers. Unfortunately, over time, that associate director no longer leaving us, and the behavioral health provider moved off to our school-based health center. So that kind of just left me kind of leading this entire, program. And I was kind of at a loss for a while of what exactly it is that I wanted to do. So I made efforts to get one of the behavioral health providers involved, just so I wasn't doing this entirely alone, being I had several other roles and responsibilities on the floor, seeing patients on the floor, in addition to other programs we're affiliated with too at the same time. So I kind of was at a loss and I wasn't sure what I was supposed to do. So in the beginning, we were actually, pretty robust. Like I had a solid plan going. I know we had our SMART goal was to get this, to have a chronic pain management group facilitated, or at least orchestrated by January 1st. The time, the date, the duration really was going to be to determine at that point. Unbeknownst to me that, several people were going to be, with the turnover rate, I wasn't exactly sure what my kind of plan was. So that's kind of, more challenges than we did really have successes, unfortunately. During that in the beginning, I did manage to work with one of our, somebody who oversees the ECW, which is our health record system. So I was able to run a registry and kind of work off that to get an idea of like which patients were coming in, which patients had this certain strength of medication, with, whose provider is it under, and so forth. So if anything that's kind of come out of this over the past few months, it's really given me an idea of better streamlining the process of pre-visit planning when patients do kind of come in. Instead of, in conjunction with the behavioral health providers, I also get in, a lot more in the room, or at least make the effort to do so when there is patient coming in. So if we can work towards cutting down significantly on the medication side of things, they approach it more from, okay, let's talk about what you're doing, how much level of activity you're getting throughout the day. Let's talk about, then they get us in the nutritional counseling portion, because we know, there's sometimes there's that association between chronic inflammation or just inflammation in general from the certain foods that we're eating. So we kind of try to approach it from that, talking about the DASH eating plan, Mediterranean eating plan. So there's a lot of things that we have been able to do, at least in the meantime, especially for myself, without kind of having the guidance or support there that I had several months prior. So I've been kind of doing my best to at least stay actively involved with this and not kind of push it off to the side. Because there was a lot of things over the past few months that I took away from it that I knew that could be certainly valuable. And, if anything, while January 1st, still isn't entirely out of the question, but just I haven't been able to honestly make as much progress as I would have liked, because there was 4 people involved with this. Now it had just been myself. And I'm curious to know if other folks that have been throughout this know of, have had, turnover throughout this, or maybe just had more challenges than they had successes, which I don't think is entirely too uncommon, given in healthcare, but also given kind of the way things have gone, over the course of the past few months, just outside of, in our day-to-day lives. So that's kind of been more out of my control than in my control, which I understand. But like I said, nevertheless, I have been still, doing my best to at least make some sort of, headway or some sort of progress in terms of collaborating more with the providers, more with the behavioral health providers, on how we can, approach this more from less medication, if of course, and having me kind of opening up my option as a resource a lot more than we did prior to the start of this program.
Yeah. So Drew, this is Aaron, and thank you for that update. And I don't think you're alone in this process in terms of turnover and really getting it sort of initially started. Like, those are kind of some of the headwinds that I think organizations face. So I would be curious as well to know that how others have been trying to work through challenges such as turnover, and still sort of keep moving. But I must say, Drew, I think you actually have made a bit of progress here. The idea that you have been able to, get buy-in from everybody that's sort of, come around about the value of, having you as a coach and having this conversation with clients about, a more holistic approach, particularly to pain, offering your services, having that discussion, with both behavioral health providers, medical providers, and, the patient themselves. And also getting, idea just from pulling the data as to, who might be the clients or patients that you all most want to target. I think that's progress in this area. So don't sell yourself short on that. I think having, an idea of who to target, using data in that way, beginning to have those conversations about nutrition, diet, how much exercise or activity are you engaged in? I think there are many organizations that would like to have that on a consistent basis. So I think, that is progress. And I think that, can, if you continue sort of moving forward, can be something that you can operationalize in a much broader way.
Yeah, absolutely. And, we're also affiliated with another program for team-based care, and how we can, and I'm speaking also on behalf on all the other FQs that could be in the group too, is that, it's very team-based oriented, trying to, and, it's very more integrative health. And as I was saying, if anything's kind of come out of this, it's really got me a lot more involved, especially on the chronic pain side of things, because it was always seen more of from a behavioral health standpoint and provider standpoint, where they were doing more of the collaborating than we were. So I've kind of, it's gotten our foot a little more in the door in regards to, taking that step back approach and observing the whole, the whole person health, as we've been talking about, rather than, just, surface level, kind of going deeper of saying, well, could it be rooted to their sleep? Could it be rooted to what their foods are consuming? Could it be rooted that they're sedentary and they're not getting the right amount of physical activity a day? So if anything, that really has broadened my, not really scope of practice, but maybe more of a a readily available option, if that's there. And a lot of the time, there's a lot of folks who are, a lot more interested. And I know that chronic pain group still is a huge interest, because we ran while throughout of this group, and I'd say in the first month or two, we got an idea of, if we were to host a chronic pain group amongst several other groups, we got a percentage, and chronic pain was the highest percentage for patients seeking that as an option for them to go to. So I know it's definitely there. Unfortunately, as I say, I'm out of control, which is how many people that I couldn't do it with. I was kind of one person leading a 4-person team initially. So that kind of really put me several steps backwards, but I think I'm going to eventually get to that point where we kind of get a new director of behavioral health, get a new associate director. I think it's definitely going to get there, but in the near distant future. So.
Yep. Okay. And and I definitely I appreciate that, and I appreciate your effort. It looks like the folks at Hope also it's like our folks I guess Bradley, excuse me, suggested that his team had also had some issues with turnover and extended family medical leave and COVID. So I think this is a very unusual environment, kind of as we said, for the top to really be trying to implement this. So definitely I think we all sort of understand and from that perspective. But as a question to sort of help kind of button this up in some ways is, what do you think is realistic? I guess maybe it's a 2-part question. What do you think is realistic in the next 3 to 4 months for you in terms of progress, or is it something that you want to try to get done in the next 3 to 4 months that you think would advance your efforts?
Yeah, that's a great question. I mean, in regards to kind of realistic, next steps, for the foreseeable, near distant future. I mean, I do generally think that once I, have at least some support kind of backing me up rather than just myself. I mean, there's of course things that on my end I can do. It just may take a lot more time than as if I had more other people backing me up. But I definitely think, if I don't do as large of a group as I would have liked, I still can do at least one-on-one coaching. If not a chronic pain group by January, I think definitely doing one-on-one coaching is still just as impactful. I mean, I know some folks do like doing group type settings. So I mean, I can even recruit for a 4-person group and just kind of start small and do almost a pilot study and seeing how that kind of plays out, which I intend to do for one of my tobacco treatment classes, which I'd planned to start up in March of this year, but that was kind of the time that COVID kind of took off and we kiboshed in-person classes. So I've been a little behind on tobacco treatment classes and so forth too. But yeah, if not one-on-one, I mean, doing a small pilot study of a 6-week group or so forth. I'm still kind of toying with the idea, but I think that could certainly be a realistic goal to have.
Okay. And I think that's a very good goal in terms of trying to start small and sort of advance this where you can, while you wait for organizationally for there to be a little more help and assistance or advocate for that on the back end to keep you going. But yeah, certainly as with kind of the first team, maybe doing the small group or the one-on-one sessions, but having that pre and post data so that you can show that potential effectiveness of the work you're doing. I think that would be a helpful addition to that too. So
sure.
Yep. But thank you, Drew. Thank you for that update, and thank you for the work you're continuing to do. So I appreciate it.
Of course. Thank you.
Thank you, Drew, and thanks for the work that you've carried along as a one-man team. We appreciate it. All right. I think that it sounds like we have Carlos on the line, so let's try to see if we can hear you. Carlos, are you there?
Hello, testing.
Yay!
1, 2, 3.
Wonderful.
All right.
All right, I will turn it over to you all at this time. Thanks.
All right, thank you, Amanda. Thank you, thank you everyone for sticking with me there, trying to get my sound going. Um, well, I'm happy to be a part of today's presentations. My name is Carlos Rivera, and I'm the behavioral health officer at American Indian Health and Services. We're located right in Santa Barbara, and are primarily, primarily our organization historically was started to provide medical and dental and counseling services to the Native American population living in the surrounding area. But aside from that, the majority of our, I would say the majority of our patients are non-native. So which is really awesome that, we can be of service to, to all people in the community. So, I want to introduce, our team, which really, they've, stuck it out with you all over the past 11 sessions. And, I got to hear some updates and then also, get a chance to be the spokesperson today. So I'd like to introduce Dr. Bradley Hope, who is, in our medical department. And I'll be talking about a little bit more about each of our departments because they also consist of our overall plan to, responding and providing services to, our patients who are suffering from chronic pain. We also have Natalia Corral, who is our care coordinator in our behavioral health department. And then we also have Vivian Benaranda, who is our KDAC counselor. So she is working with all of our, patients who are in need of whether it's outpatient or inpatient treatment surrounding substance abuse. So this is our team. And what I want to present for you today is really it's our plan. It is our plan. It's our vision for what we hope to implement in the next, hopefully, in the near future. I'm looking at, early part of next year as we begin to, really now after everything that has been, presented by all of your, presentations and, everything that our team has, really learned from you all. We plan to, implement, a lot of those resources and services. So if I can get the next slide, please. Next slide, thank you. So, another thing that, anytime we are looking at, the health of our community, the health of our tribal communities also specifically, we can't present anything and leave out some very important factors that really result in what we are experiencing today, such as chronic pain. I mean, it's not only the, the other, substance abuse or addictions and other, issues that our communities are dealing with, but really it includes everything. And so when we take a look at what has happened, to our tribal communities a long time ago, which was, there's been many policies that were put in place at one time to basically exterminate, the Native people living specifically in California. The state of California at one time reimbursed over $12 million in Native American bounties. And so those are things that aren't talked about, a lot, but yet they play an important role in what we are experiencing today. So this image here is a image of a boarding school that was, one of the policies that was put in place to assimilate Native American people was to put them in boarding schools and to learn a new way of praying, to learn a new way of thinking, to be given a new name, to be given a new identity, and not just by choice, but it was by by force, and then also to forget about and unlearn what you learned from your tribal community. And so if you can click on the or advance the slide, there's going to be some language that pops up. So I like to look at this as resiliency, and not just call it historical trauma or intergenerational trauma, because although it was traumatic, and we know that that has been passed down from generation to generation. Although we know that's true, but I also look at what our ancestors have given us, and they taught us resiliency. And they taught us that that they were able to live through, and not only just live, but also hold on to our language, our songs, our dances, and our traditions. And there was 1% of the overall population that survived. 1% of millions of Native people that died during past pandemics. During other atrocities. This isn't the first pandemic that we've been through when we take a look at even in the past. So when I look at this topic of alternative to pain management, I really look towards our culture as pain management. And I think that for us, that's one of the approaches that we are looking at is not only looking at it from a Western perspective, but we want to take a look at it from an indigenous perspective. Because when I look at our culture and our traditions, not only were they anger management, not only was it culture is prevention, but our culture is also pain management. And I think that when we look at it from that perspective, that really brings in that holistic approach to what we're going to be doing at American Indian Health and Services. If you can forward the slides, please. So just kind of taking a look at some of the activities and the goals that we've identified. So what we want to do is organize care, for our patients who have a long history of addiction. I think that again, when we look at pain management, addiction, whether it was alcohol or drugs, became a way of dealing with the pain. And so not only do you have this physical pain, and then now there's an addiction that forms because of it, and then that continues to impact that person's life. So we really want to take a look at improving our spurt screening frequency and track, and document those changes. I think that that's something that we could always improve on, and so we're taking a look at that. We want to track quantity of pain medication, over 90 days, and then see if the quantity changes. We hope it does go down with more comprehensive, systematic care. Our activities. Again, because of the pandemic, and I really, thank our leadership in the administration department for really guiding us through this pandemic in the safest way. I think that there's been a lot of, maybe even in the community or even at the state level, a lot of things kind of opening up and maybe even kind of relieving some of their restrictions. But our leadership continues to be consistent all the way through, and I'm grateful for that, because I think that we're healthy today, and I most of our staff continue to work through the pandemic, whether it was in person or remotely. So we did, because of that, we did not carry out any in any of the plans yet, which is really group activities. Really, that's one of our biggest, I think for me, is in the behavioral health department, is to really hold space for our patients who are going to be working with not only the medical department, but maybe the dental department, the community wellness department, and also the behavioral health department. And so to be able to hold space and provide that opportunity so that not only are we providing, care, like again, whether it's medically or counseling, but also that safe space to express. And I think that, that's one of the things we're going to be implementing very soon. So we did formalize this plan, and we hope to carry this out in the near future. If you can advance the slide, please. So some of our changes, providers to be notified to refer this population to behavioral health. Basic services will be organized in different ways and allow tracking of 10 patients with pain and addiction. So we're really looking at staff involvement. We're looking at a level of care for mental health and referrals, to be documented and done appropriately. Some of our next steps, if it seems beneficial that we can make this our new norm, we can begin and recruit with 10 to 20 participants and review the results to decide if we should continue with this approach. And I think that, looking at 10 to 20 patients, and really, kind of following them through the process, really help us to really identify some of those challenges that we're going to have to, address or maybe make some changes as we move forward. So we consider adding assessments, for patients, support network, spirituality, and address attachment disorder issues if present. Can you forward the slides, please? Strategies for success, inform providers, again, to refer to behavioral health chronic. Let me back up a little bit. Now I'm just reading off the slides, and every time I do that, I slip up. So just kind of looking at our strategies, I think that, again, looking at our providers, looking at our referrals, specifically with patients who have chronic and a history of substance abuse. Again, recruiting 10 participants, follow through with the screening and assessment, refer to our substance abuse counselor, which would be our KDAC counselor, Vivian. So when you take a look at our team, we really have, that wraparound care. And I think that that's a highlight for us, and shortly here, I'm going to show a slide in where we put, our department in what we call a medicine wheel, which is a circular image, and really provide that, again, that indigenous approach to it. So we want to determine the level of care and coordinate, within our clinic, the best appropriate services, again, addressing challenges, as stated above. We will have behavioral health staff initiate these screenings with patients, and make it more accurate and minimize any barriers. I think that that's going to be huge, is to always look at it from that angle, is minimizing, any barriers. Key challenges, recognizing of clinic due to COVID issues. So like Dr. Hope just, recently stated in a comment that it's been challenging because of COVID. We've had, in medical, they've had some staff turnovers, and it's been very challenging to even transition at times from, in-person to remote. So just some things there. If you can forward to the next slide, I know we're short for time here. So here is our medicine wheel, and I'll just kind of walk you through this. Maybe some of you are familiar, maybe some of you are not. But in this image, this circular image is very universal to a lot of our tribes. It's called the medicine wheel. And in the center of the medicine wheel is what we call the original source of creation. And from that original source, all of life was then created. Not only the human being, but also also the creatures, the animals, every living creature comes from the original source. And so some ways we are all related from that perspective. We're all related if we come from that original source. Can you click on the advance the slides and some colors will pop up? Keep going, please. So those colors are also universal. You know, whenever we see a medicine wheel image, you'll see these colors, and what those colors represent is, again, all people, no matter what color of your skin is. And so, you know, I love working at AIHS, and also, you know, not only working with the native population, but working with all the community. And to me, that's a sense of belonging. And so we take a look at in the physical direction. So there's 4 therapy targets, what we call them, 4 therapy targets. And those 4 therapy targets are physical, mental, emotional, and then spiritual. So if you could click on the slide, keep going until the 4th one comes up. There it is. One more, I believe. Okay, so we look at these 4 therapy targets, and we look at it from an indigenous perspective, which is physical, mental, emotional, and spiritual, and then we add in our department. So at AIHS, we not only have medical, but we have behavioral health, we also have dental, and then we also have community wellness. And so each of these departments really, you know, work with one of those areas of the person, you know, whether it's the physical, whether it's mental, emotional, and spiritual. And so when we look at, again, the physical pain, it impacts the mental, you know, it impacts emotionally. It also impacts us spiritually. And that to me, that is alternative to pain management. You know, it's not leaving out one and working only with 3, or leaving out 3 and working only with 1. So we really want to bring it all together, the whole person. And we look towards not only the medicine wheel, but we look towards our environment as teachers as well. Can you forward the slide, please? So what comes next? You know, identify more team members to implement, you know, our groups. I think that, you know, the group that has gone through, our team members who have gone through this series, really is going to be the foundation, but we're also going to need more support. And so that's one of the things we've learned is, you know, really looking towards, you know, more support as we move forward. We learned the value in collaborating, you know, between medical and medical, behavioral health, dental, and then also community wellness. I think that out of this series, and along with, you know, kind of some pre-existing visions that we already had, you know, we really wanted to tighten and bridge the gap between our departments. And this is really helping us to do that. So if you can forward the slide, please. Thank you. All right. Well, I know it was a short presentation. I could go on for days with, you know, with some of those slides. I could park on one of those slides for for a whole day if I needed to. But with that, I'm just gonna you know, kind of end my presentation, and then also open it up to any questions. And then even my team, if I left anything out, or if it triggered or it activated a thought for you, you know, please jump in there and share that. You know, I really look towards you also for support. So thank you, Amanda.
Thank you. That was wonderful. I can open it up to the rest of the AIHS team to see if there's anything else that you want to add before we open it up for other thoughts and reflections.
All right. So I take that as I covered everything.
You know,
Great job.
yep. You know, Carlos, I really want to say, you know, I appreciate the fact that you sort of, you know, added in, you know, had that initial conversation in the beginning and talking about, you know, all of the things that sort of might impact pain, including some of those, you know, historical and generational sorts of things, because you're exactly right. You know, that is a part of that conversation about, you know, chronic pain and how do you help people move towards sort of wellness in a very holistic way. So I appreciate you sort of bringing that back to the forefront of this conversation. I think that's something that as a part of the work, for certain people can be explored as a part of this too. So, thank you for doing that. So
I appreciate that, Aaron. Yeah, I appreciate those comments. Yeah, something that is very relevant for, when we're talking about pain. Again, that's, the pain is, sometimes I look at even the addictions is, those are on the surface, right? And then, so in behavioral health, we want to take a look at it, from a deeper understanding of, well, what caused the pain, and, and what else can we look at to address. So thank you.
Yep,
All right.
exactly. Thank you. I appreciate it. Yep.
Yeah.
All right, so I think Amanda, we have. Does anyone else on the line have any questions or comments about the presentation? Anything they want to ask the group? Okay. So I think we have one more
Okay.
update.
Yep, we have one more update. At this time, I will turn it over to the One Community Health team.
Okay, thank you. This is Andy Luckett, Integrative Medicine Coordinator and Family Physician here at One Community Health in Sacramento. Part of our team is our nurse practitioner, Keith Udelman, who is also one of our acupuncture providers, and Shelley Henderson. Dr. Shelley Henderson is a psychologist that works with our patients here and has a special interest in working with patients who have chronic pain, and sort of the intersection, as many people have discussed, between mental health, behavioral health, and chronic pain. And so I apologize we don't have our slides in today. I had a issue with that, but I can go through sort of the points that we as a team have worked on so far. And the projects that we sort of focused on initially were a combination of different things. But in general, just sort of trying to figure out how to standardize and optimize pain management at our FQHC via introducing new treatment options, visit types potentially, and increasing provider education around the subject, as well as increasing resources for those providers to use during their clinic. We had a few wins during our process, and those included initially we did an assessment of providers, and unfortunately the majority of them out of 5 had, would say, their experience taking care of patients with chronic pain at our clinic was either a 3 or less. And so we felt with that information along with a few other questions that we did in our provider resource survey, that the time was ripe to make some changes. So things that we've had success with so far included creating a pain intake form or a questionnaire for patients to fill out before their visits for chronic pain. This is in pilot right now with a handful of providers, and we are also working to get it built into our EHR so that we can use it as a monitoring tool. We sort of looked at the different tools that were out there and pick and choose the questions that we like the best and sort of put them together in our own form and questionnaire. We also had made plans to work on a visit template for providers that we haven't actually gotten to yet, but is still in the works. And I still hope to bring that to fruition. And one other thing that we were able to do with Dr. Henderson and myself is we had already prior to this had a team established that to review patients on high dose opioids, but we were able to start doing a shared medical visit with her and I meeting with the patients together to talk about, you know, the difficult process of tapering down on those medications, as well as figuring out, you know, how can we address their pain in a holistic manner so that the patient didn't feel like we were leaving them out to dry without doing anything else, that we still wanted to care for them and be a part of their health care. And then it was also an opportunity for them to meet Dr. Henderson, because we found that, you know, as much lip service and recommendations we could give for her, there's just something that is unique about meeting a person and getting a real feel for them to be able to give the patient confidence that, yes, this is someone that I think can help me with my situation going forward. And we've just done a handful of those visits so far. And we've got another provider who will be joining us doing those sometime here in this near future. You know, in doing this work, I think the things that we noted as challenges was just a lack of time, number one, among all the different team members to be able to get together regularly. And so as we started to notice that initially, we were having a meeting once every other week, and we're discussing what we wanted to do, and we say, okay, we'll look at this, and then we'll come back next time and sort of share with each other what we've done. And after that didn't happen, maybe once or twice, we said, okay, maybe we just use this time to actually work on it all together. And so it was helpful to really just be able to organize it a little bit better and make use of our time. And the other thing that we hadn't yet accomplished, but I still hope that we can, is do some provider education about what the standards of care are around treating chronic pain and opioid prescribing. When we met with Aaron, he was able to give us some good resources for that, and we'll hope to reach out to them to get someone to one of our provider meetings and do a little bit of provider education about that, because that was another thing that providers stated in our questionnaire, was that they would want more education in this subject. So I'll open it up now to our other team members to see if there's anything that they wanted to share. Oh, there was one other thing that we did during this meantime was we had been offering acupuncture, but we started offering it sort of in a grouped capacity where patients weren't actually in groups necessarily, but we were able to have more visit exam rooms available to them, and they would be scheduled like 4 patients per hour at the beginning of the hour. And we were able to increase the capacity for our patients to get acupuncture that way, rather than scheduling them like our medical visits, one visit, every 20 minutes on a rolling basis. We found we had some no-shows, and our visits weren't able. We could never do 3 in an hour that way because the patient needs to be in the room for at least 20 or 30 minutes. So if we scheduled them all at the beginning, we were able to get them all in, get them seen, get the needles in, and have them be able to lie there and get that all done within the matter of about an hour before the next group was set to be seen. So I think that's been a success for us so far. Anything y'all else want to share who are on the call?
Keith here, I'll jump in real quick. I think Andy covered everything pretty thoroughly. I guess the one other thing, which wasn't exactly on our list, but another provider was already working on it, and so it happened to fit in well once we were kind of setting aside some time to address trying to standardize our pain management situation, is we've been working on a low literacy pain contract for our folks that are on long-term opioid therapy. And that also is not quite complete, but we've been working on just kind of simplifying it and shifting some of the language, because right now it's a fairly complex, I think, 6-page document that is could serve some of our patients better if it was a little bit shorter and concise and easier to read. So.
Yeah, so if anyone has any questions about the work that we did, we're certainly open to answering those.
So, Andrew, this is Aaron. So I was trying to one thing I had. Thank you for the presentation. One thing I wanted to know is, are you doing anything to like going forward? What is something you want to work on that I know you have a number of things you already sort of done, but going forward in the next, say, 3 or 4 months, what is something you want to work on that might be helpful?
I think the provider education is something that I'd like to see happen. Having a national expert come in and give our providers a little bit of education around appropriate prescribing practices and pain workup and that kind of thing.
Okay. Thank you. That's helpful, guys. Because this is, I really like the fact that you all did, that assessment of providers in the beginning, sort of asking them sort of, where they are, sort of what they needed to move forward, and then really, looking at how you can provide tools for them to work better in this space. I think that's a great approach for this.
Yeah, it gave us an idea of, okay, rather than us just saying, here's what the clinic needs, let's find out what providers actually feel. And they also stated that they would be interested in having a template built for their visit notes for chronic pain. So that would be another thing that I'd like to get together in the next 3 to 4 months.
Great. Thank you so much for sharing. Do others have questions for Andrew, Keith, and the team? All right, we can open it up to see if there are any other kind of general questions on any of the other presentations today, thoughts folks had on kind of sharing other strategies or resources, or just general, you know, comments you wanted to add at the end of today's session. All right, so as you all know, we only have one session left, which is scheduled for November 11th. We really appreciate all of your sharing today, your preparation that you've gone through over the last few months, and for today's session. As we kind of close out, our last session will really just be an opportunity for additional reflection and resource sharing from our side. So we wanted to just offer up, if there's anything that would be helpful for you to meet with Aaron and I over the next few weeks, from now until November 11th, we're happy to do so. If you would like to kind of have a call to go over any next steps or questions that you have on your action plan, do feel free to reach out to us, email us, we can connect. We're happy to have a conversation about it, if that would be helpful to you. Aaron, I saw you unmuted. Is there anything you wanted to add around that?
No, I think that's pretty much it. Just we're open, you know, as we're, you know, coming to a close, we want to make sure that you all are, you know, sort of best situated to move forward and do all the things that you all are interested in doing going forward to address this. So if there is a, you know, anything you want to talk about, a plan you want to discuss, you know, we're open to that, you know, up through the last, you know, meeting on the 11th. So.
Great. All right. Well, thanks everyone for your presentations today. It was really nice to turn the gears and hear from you all instead of us doing the talking. So we appreciate your participation, your questions throughout, and we look forward to connecting again in a couple of weeks.
Yep. Thank you all. See you on the 11th. Thank you. Yep. Let us know if you need anything.
Thanks, everyone.
Thank you all. Bye.